This presentation will discuss the concept of perfusion, specifically related to hypertension. There are many different causes of hypertension, and then there are types of hypertension, such as essential hypertension, that we don't understand the cause, or there is no known cause. Other causes of hypertension include disorders of the adrenal glands, where the secretion of epinephrine and norepinephrine cause hypertension, chronic kidney disease, which results in fluid accumulation, which causes hypertension, and then structural problems with the heart and surrounding vessels, such as coarctation of the aorta or valvular disorders, heart failure, and other cardiac etiologies of hypertension. Cushing's syndrome, where you have increased cortisol production, which causes fluid accumulation or retention that contributes to hypertension. Certain drugs can cause hypertension, as can obstructive urinary disorders, such as kidney stones, tumors, and other things that may block the flow of urine from the kidneys to the bladder. Parathyroid disease can cause hypertension. Pheochromocytoma is actually a disease of the adrenal glands where they produce too much epinephrine and norepinephrine and cause what we call malignant hypertension, which is hypertensive crises where the blood pressure is usually in the 300s over 200s and is very difficult to control. And then renal stenosis and decreased renal perfusion, as in damage to the vessels that feed blood to the kidneys. Sleep apnea may cause hypertension, and thyroid disease may cause hypertension. I've given you a website here that discusses each one of those causes of hypertension very in depth. It's a layman's website, but it's a great little website. And then for you visual learners, I've given you a couple of pictures of the different parts of the body that are affected by hypertension. In 2017, the American Heart Association changed the parameters for hypertension. And this is the first time that these guidelines have been adjusted since 2003. And so I wanted to go through those relatively new guidelines. These guidelines were developed because statistics show that we are not taking hypertension seriously enough, and that typically in the past we were not implementing treatment for hypertension at levels where we could actually intervene and decrease the incidence of hypertensive problems before they even got started. So a statistic that's really important is that death from ischemic heart disease and stroke doubles with every 20 millimeters of mercury rise in the systolic or 10 millimeters of mercury rise in the diastolic blood pressure. And this was looked at from people to 40 to 89. So what that is telling us, if you think about it, if you have a blood pressure of 180 over 90, your chance of heart disease and stroke is way more than double. And so it's almost inevitable that patients with that high of a blood pressure range will develop some kind of cardiac difficulties. So the new guidelines encompass that a normal blood pressure should be less than 120 systolically and less than 80 diastolically. So 119 over 79 would be the top acceptable normal blood pressure. So elevated blood pressure starts at 120, and from 120 to 129 systolically, that's considered elevated. And hypertension stage 1 is a systolic blood pressure between 130 and 139, or a diastolic between 80 and 89. Stage 2 is a systolic of 140 and a diastolic greater than 90. And then your hypertensive crisis is defined as a sudden increase in blood pressure that exceeds 180 systolic or 120 millimeters of mercury diastolic. So this lowered the acceptable normal blood pressures and classifications of blood pressures just a little bit. When assessing a patient for hypertensive risk, there are some very specific things that you need to be evaluating. Your BMI values, anything that is 18.5 to 24.9 are considered normal and put the patient at very little risk for hypertension. Once the blood pressure once the BMI gets above 25, from 25 to 29, and a patient is classified as overweight, then we start to worry about hypertensive risks. And you can see that the body mass index, the higher it gets, the more likely the patient is to have hypertension. And then waist circumference is also important. When we talked about diabetes, we talked about the metabolic syndrome, and basically that metabolic syndrome doesn't just apply to diabetes, but also to hypertension and cardiac disease as well. So when we look at that metabolic syndrome, we're looking at waist circumference, and we want the waist circumference to be less than 40 inches in males and less than 35 inches in women. Ethnicity is a factor that plays into hypertension, especially for African Americans. The rate of hypertension in African Americans is much higher than any other ethnicity. And so 59% of African American men and 56% of African American women have high blood pressure. Some of that is directly related to genetics. So treatment of hypertension. In order to effectively treat hypertension, we have to evaluate and make recommendations to patients for lifestyle modification. We're looking for those lifestyle habits that are modifiable versus those that are not modifiable. This slide points out an interesting phenomenon in that African Americans who live in the United States have a higher incidence of hypertension than Africans who live in other parts of the world. And so it's very odd that this is what's going on, but when we look at the factors, it shows that some of these could be simply related to exposure or lack of ability to obtain health care in the United States. So we know that genetic factors have something to do with African Americans having high blood pressure, but that's not the only thing. So it's also thought that African Americans have an increased sensitivity to salt, and that we are more exposed to salt in our country from the processed foods and the fast foods that we have. We also feel that part of that is due to a disparity in access to education, preventative health, and access to medical care. And so I put a reference here that if you wanted to go back and read about this, you can. Now, our modifiable risk factors, obviously, genetics is not a modifiable risk factor, but these things are. So we can modify our chance or decrease our chance of getting hypertension by following a DASH diet. So you're talking about low sodium, low fat. We also want to restrict sodium to less than 1,500 milligrams a day. Now, 1,500 milligrams a day is not much at all. And some patients who cut their diets down to 1,500 milligrams a day will actually develop sodium deficiencies. So you may see diets anywhere from 1,500 to 2,000 as an acceptable low sodium diet. We also encourage our patients to have an increased potassium intake of 3,500 milligrams a day, to increase physical activity to a minimum of 30 minutes of exercise 3 times per week, and alcohol intake should be limited to 2 drinks or less for men and 1 drink per day less for women. When lifestyle modification doesn't work, then we have to start looking at other therapies, including pharmacological therapy. And most of the time when they're evaluating a patient for hypertension, the physicians will look more at the systolic blood pressure than the diastolic. And the thought behind this is if they treat and manage the systolic blood pressure, then the diastolic blood pressure will follow and become normal. So most of the time when you see parameters, and what I mean by parameters, I mean instructions that tell you when to hold a medication or when to give a medication, most of those do focus on the systolic blood pressure and not the diastolic. So when we're talking with patients about pharmacological treatment, it is very frustrating for both the practitioner who's prescribing the medications as well as the patient. It is almost never achieved by using just a monotherapy or a single drug to manage hypertension. Usually it takes several different drugs, and it takes multiple months to regulate a patient on a good combination of drugs. And so this is not an easy process. This requires a lot of follow-up. It requires the patient to come in for visits frequently so that we can monitor their blood pressure and make adjustments as necessary by either increasing or decreasing the doses of one medication or adding on more medications to manage blood pressure. So we need to be very good at supporting our patients and giving them the psychosocial support that they need during this time, because it is very, very difficult for them to understand that it takes a little while and that there's no set treatment for each patient because it is very, very individualized. So in order to come up with an appropriate treatment, we look at the 2 driving forces of hypertension. So the 2 things that cause hypertension are fluid accumulation and vasoconstriction. So what we have to do is focus on managing fluid or vasoconstriction or both. So most of the pharmacological therapy that we're talking about will either decrease fluids or increase vasodilation. So this slide just kind of shows you about hypertension and what causes it. So you have pressure that pushes in from vasoconstriction, and you have pressure that pushes out from intravascular fluid. So fluid in the vascular space pushes on the walls of the vessel, and the walls of the vessel push in on fluid. So you see fluid pushing out and vasoconstriction, or the tone of the vessels pushing in. And that's what makes up our blood pressure. So if we're going to change someone's blood pressure, we have to focus on changing one or both of these two factors. So our primary medication therapies are diuretics. And the goal of diuretics is to decrease intravascular fluid volume. And so the first line treatment is usually with a thiazide diuretic, and the drug of choice is hydrochlorothiazide, which is often written as HCTZ. And so our first attempt at lowering the blood pressure would be to remove fluid from the vascular space and see if that alone will bring down that patient's blood pressure. Other diuretics that we might use include the loop diuretics such as furosemide and torsemide, and potassium-sparing diuretics like spironolactone. If lifestyle modification doesn't work and diuretics alone are not effective, then we move into our secondary medication therapies, which include our true antihypertensives. And I've listed those out for you here. We're going to go over these just a little bit later, and so I'm not going to go through them right now, but there's a list of some of the medications that you would see. Now, this right here is why it's very important for you to know your generic endings. All of your LOLs are going to be beta blockers. Your ACE inhibitors are going to be prils. Your calcium channel blockers are mostly going to be pines, P-I-N-E. And your alpha blockers are azosins. And then you've got your sartans that are your angiotensin II antagonists. And so if you know those generic endings and what class they go with, it will help you learn these drugs a lot easier. This slide is a little hard to see, so I did give you the website that you can copy and put it into your browser, but this talks about where in the body each classification of antihypertensive works. So you can see, for example, that the calcium channel blockers work on the blood vessel, as do direct arterial vasodilators like hydralazine. And so this just is a visual picture to help you, if you are a real visual, to understand where in the body these individual drug classifications do their work. So angiotensin converting enzyme inhibitors, or your prils. These are called ACE inhibitors for short. And they inhibit the enzyme that converts angiotensin 1 to angiotensin 2. So angiotensin is a chemical that causes the arteries to vasoconstrict, and it is specific to the kidneys as well as throughout the body. So we know that we can't allow our kidneys to have a lot of vasoconstriction, because when the blood gets cut off or lessened, then we have kidney damage, which directly leads to hypertension. So these ACE inhibitors, or angiotensin converting enzyme inhibitors, help the body to decrease angiotensin production, which allows more vasodilation to allow blood to flow through the vessels easier, which lowers the blood pressure. Diuretics, we talked about, they get rid of excess sodium in water to help decrease the pressure on the vessels and decrease peripheral resistance. And we've already talked about these. You do want to understand the difference between potassium sparing and potassium wasting. So when you give a potassium sparing diuretic like spironolactone, you have to watch the patient's serum potassium to make sure that it doesn't go too high. That may mean limiting their potassium in their diet. And the potassium wasting, um, these decrease the serum potassium. The potassium gets excreted with the urine, and so it drops the serum potassium. And both your thiazides and your loop diuretics, like furosemide and torsemide, will waste potassium. So for those patients, we may have to give potassium supplements or increase potassium-rich foods in their diet. So things like obviously bananas, potatoes, some of your other vegetables, those are important in helping a patient increase potassium when they're taking a potassium wasting diuretic. Now, it's not uncommon to see somebody be on both spironolactone and perhaps furosemide. So they'll put the patient on a potassium sparing diuretic and a potassium wasting diuretic. And what they do is they basically cancel each other out to help maintain a normal potassium level. So if you see a patient on both of those classifications of drugs, that's typically what's going on. Beta-adrenergic blockers are perhaps the most common antihypertensives behind diuretics. They're usually the first drug to be prescribed when diuretics alone don't work. Now, these drugs actually turn down the sympathetic nervous system by decreasing epinephrine, or the effects of epinephrine on the sympathetic nervous system. So they block the sympathetic nervous system, which controls your heart rate and your blood pressure. So by blocking stimulation of the sympathetic nervous system, we can turn the heart rate down and we can turn the blood pressure down. Now, I put the parameters on the beta blockers because you definitely need them with beta blockers, but you need them with other antihypertensives as well. I just want to put it on each slide. But with most of the drugs, when you look at your MAR, you're going to see that there's usually a parameter with blood pressure medications that would say something like hold for heart rate less than 60 if it affects the heart rate, and hold for systolic blood pressure less than 100. And then sometimes you might see a diastolic number, which is usually less than 60 as well. Now, the thing about beta blockers is that they are typically not used in African American males because African American males don't respond well to beta blockers. Their hypertension is not mediated usually by the sympathetic nervous system. And so, in order to effectively treat our African American males, we need to be careful and make sure that we're not starting them off with a beta blocker, that we might be using a calcium channel blocker or some other medication that is in a class other than your beta blockers. Because if we start them off on beta blockers and we're not treating them effectively, then they could have a stroke or an MI or cardiac dysfunction, um, or other problems. So it's just really important to understand that. Now, when we're talking about beta blockers, it's really important for you to understand that every beta blocker is not the same. And so there are subtypes of beta blockers, and those subtypes are selective and non-selective. And the selective beta blockers are beta blockers that affect both cardiac and lung tissue by affecting that sympathetic nervous system. And so they don't select a certain type of tissue to affect. So that means they're non-selective. So our beta blockers that are non-selective are not safe with asthma patients because they tend to cause bronchoconstriction. And what that bronchoconstriction can do as a side effect is to induce an asthma attack or make respiratory distress, like somebody with emphysema or chronic bronchitis, um, worsen because of bronchoconstriction where they can't move air in and out. And so it throws them into respiratory distress. We also have to use our non-selective beta blockers carefully in patients who have diabetes, because when somebody becomes hypoglycemic, they know they're hypoglycemic and we know they're hypoglycemic, typically because they become flushed, they sweat, they have tremors, and all of those are symptoms of hypoglycemia that are initiated by the sympathetic nervous system. So if we're giving a patient a beta blocker that affects the entire sympathetic nervous system, then these patients will not have the typical signs and symptoms of hypoglycemia, so they can become profoundly hypoglycemic without symptoms because those symptoms are being masked by the beta blockers. So the best example that we have of a non-selective beta blocker is propranolol. It's probably the oldest beta blocker that we have. It's a very good drug. It is a great drug for stress and anxiety and problems with test taking even, because in a very low dose, it doesn't really affect the blood pressure, but it does affect the sympathetic nervous system to help calm the patient or reduce tachycardia and hypertension and other things that are induced by anxiety. Now, the other two subtypes actually fall under the subtype of a selective beta blocker. And we have two different types of selective beta blockers. So we have our beta 1 blocker, which ends in LOL. And if you remember that you have one heart and that a beta 1 blocker affects the cardiac tissues only, then you'll remember that these drugs, because they only affect the heart, are safe for patients with respiratory disorders. These do not cause bronchoconstriction. They do decrease the heart rate and the blood pressure, so we have to be careful, especially with the heart rate, and make sure that the patient isn't becoming bradycardic from these drugs. And the drugs of choice, or the drugs that you see most often, are metoprolol and atenolol. And then we have our beta 2 blockers that end in TEROL, terol. And you remember that beta 2s affect the lungs. You have two lungs, and your beta 2s affect those two lungs. So what these do, opposite of your non-selective beta blockers, is that they actually bronchodilate the lungs to open the lungs up. And we will be talking about these drugs a lot more when we talk about the concept of oxygenation, because with the action of bronchodilation, they open up the airways where the patient can breathe better. So these are often administered as inhalers and nebulizers. We see them much more for treatment of respiratory disorders than anything else. So albuterol, isoproterenol, there's quite a few other drugs that you may see that fall into this category. Um, some of these may induce anxiety and tachycardia, especially in children. So that may be a dose limiting problem. In other words, if it causes tachycardia or anxiety, we may have to either back down the dose or change to another drug. And the drug that is most commonly used is albuterol, even though there are quite a few others of your selective beta 2s. Then we have our angiotensin 2 receptor blockers. So remember, our ACE inhibitors inhibited the conversion of angiotensin 1 to angiotensin 2. Well, these drugs, the angiotensin 2 receptor blockers, block the action of angiotensin 2 on the blood vessels. So it blocks vasoconstriction, allowing them to remain open to decrease the blood pressure. So they block receptors. Angiotensin fails to constrict the blood vessel, and so there's less peripheral resistance, and blood flows more easily, which decreases the blood pressure. These all end in sartan, or the greatest majority of them end in sartan. So we have losartan and valsartan. And we have calcium channel blockers, or our penes, such as nifedipine and amlodipine. And our calcium channel blockers, they actually prevent calcium from entering the smooth muscle of the heart and of the vessels. Remember that your vessels are muscular, and so if we inhibit the calcium channels, then what that does is it causes relaxation of the heart and of the vessels, um, and so it increases the vasodilation that allows the blood to flow easier, and it slows the heart rate and decreases the contractility of the heart. And this both reduces the heart rate and the blood pressure. So next we have our alpha adrenergic blockers, or our azosins. This includes doxazosin, prazosin, and terazosin as some of the most popular ones that you'll see. We don't see these a ton. Obviously, we're going to see our beta blockers and our calcium channel blockers and ACEs and ARBs first. Um, these drugs work to decrease the resistance of the artery walls, and so it makes them more pliable and more easily dilated to decrease the blood pressure. So as we talk about these different drugs, you can see that almost all of your true antihypertensives, except for your diuretics, work by causing vasodilation. It's just that each class causes that vasodilation by a different mechanism. So if we're inhibiting the calcium to relax the vessel walls with the calcium channel blockers, or we can be blocking the conversion of angiotensin 1 to angiotensin 2, or we can truly block angiotensin 2 at the receptor sites. So as you look at these drugs, the big difference is not necessarily what they do, but how they do it. Because our best way to manage hypertension is going to be, number one, dump the fluid, and number two, relax the vessel walls by one mechanism or another. Alpha 2 receptor antagonist, these drugs decrease the effects of adrenaline on the sympathetic nervous system. And so by decreasing that adrenaline, we turn the response of the sympathetic nervous system down, such as lowered heart rate and lowered blood pressure. Again, these drugs right here are not all that common. However, methyl-dopa, which is the most common drug in this class, is used in pregnancy-induced hypertension because it doesn't have the effects on the mom and the fetus that some of the antihypertensives do. So it is safe for pregnant mamas. Then we have our direct acting vasodilators like our hydralazine, and these do as well relax the muscles of the blood vessel, causing vasodilation to reduce the blood pressure. Now, hydralazine is not often used as a maintenance medication like many of these other medications that we talked about. It is used more often as a drug to reduce the blood pressure quickly when we have a hypertensive crisis. It can be given IV, and so when somebody comes in and we try to treat them for hypertension and their blood pressure persists and we can't get it down any other way, a lot of times they'll give an IV dose of hydralazine. The other name for it is apresilene. anytime you see a drug that's got press in it, PRESS, then typically you know that that has to do with blood pressure. So a Presaline drops the blood pressure very dramatically. And it will do that as well in the oral form if a physician is using it for a maintenance medication. Um, and it's very difficult to manage. It can cause severe, rapid drops in blood pressure. So we have to be very careful. And if somebody's going to go home on hydralazine, as with some of these other medications, we want to make sure that they get their first dose while they're in the hospital so that we can monitor them. Now, this slide I put in here to show you what we call the step therapy. And this demonstrates how a practitioner goes about ordering your different blood pressure medications. So we start off as the foundation with modifiable risk factors. When that doesn't work, we go to the first step, which is our thiazide diuretics. If the thiazide diuretics alone don't work, then we go up to the next step, which is usually beta blockers for those patients that aren't African American, or ACE inhibitors, ARBs, or calcium channel blockers. And if those don't work, if the initial drug doesn't work along with the thiazide, they'll either increase the dose or add on another medication. So each step up adds on something else. And so this is why in the clinical area, you'll see patients on so many different medications because it took that many steps to get their blood pressure controlled. And remember that it is very individualized because each patient has a different combination of factors that contribute to their hypertension. It might be the kidney, it might be the adrenals, it could be the thyroid. And so all of those different factors together make up each individual's cause or etiology of hypertension. And so we have to individualize and work with those patients to make sure that we are finding the right combo to take care of whatever's initiating their hypertension. So in preparation for the exam on this material, please make sure that you're going back and looking at the website that I gave you regarding the effects of hypertension on the body, especially in terms of the kidneys and the eyes. And remember that sometimes it's very difficult to tell, did kidney failure cause the hypertension or did hypertension cause the kidney failure? Because increased blood pressure destroys the vessels at the glomerular level inside the kidney. And if that hypertension destroys the glomerulus or damages it, then the kidney can't excrete water, which causes water retention, which turns right around and causes even a higher increase in hypertension. Likewise, if somebody has kidney damage due to drugs or overuse of NSAIDs or something like that, then as the kidney is affected, it will cause water accumulation, which will then cause the hypertension to develop. So it's very difficult sometimes to decide, did the kidney fail first and cause the hypertension, or did the hypertension occur first and cause the kidney to fail? So also look at the different parts of the body that are affected. Like I said, the website that I gave you gives a very good explanation. It is a layperson website that was written for patients, but I liked it because it was very simple and very clear and easy to understand. It doesn't give you a bunch of stuff. It just gives you what you need to know. And so I thought it was a good choice. So this ends the part 1 of perfusion that deals with hypertension. Additionally, in this series, we will have presentations on heart failure, anemia, and PVD.